started as everyone joins the webinar today. Good morning, good afternoon, good evening, depending on where you're joining us today in the world. Thank you so much for joining us on this webinar, and welcome to the Hepatitis B Foundation's webinar that will provide an overview on the recently published World Health Organization Hepatitis B treatment guidelines. My name is Catherine Freeland, and I'm the Associate Director of Public Health Research at the Hepatitis B Foundation, and I'd like to welcome you to today's webinar. A bit of housekeeping before we get started today. This webinar is being recorded. It's also being live streamed on our Facebook page, so please feel free to join us on either venue. Additionally, this webinar will be recorded and shared with all registrants who signed up to join this webinar and will be available on the Hepatitis B Foundation's Facebook page. We're using the Zoom webinar platform, so you are in webinar mode. However, you can use the chat feature throughout the duration of the webinar. And if you have any specific questions for any of the panelists, please be sure to use the question and answer box. My colleague, Anusha, and I will be monitoring the questions throughout the session, and we'll be doing our best to make sure we get to all of your questions during the discussion section. Just a bit of an agenda for our conversations today. First, we're going to be sharing briefly about the Hepatitis B Foundation, and this will be followed by an overview of the WHO Hepatitis B guideline updates from Dr. Philippa Easterbrook. And then this will be followed by question and answers and responses from an esteemed panel. So first, I'd like to share a little bit about the Hepatitis B Foundation. We are a nonprofit dedicated to improving quality of life for those working and living with hepatitis B, and we're also working towards finding a cure for hepatitis B. Our public health programs include patient consultation for those with hepatitis B and family members. People reach out to us to get questions answered or help understanding their lab results, and they get answers by expert staff on topic. A robust website with reliable and factual resources on all things hepatitis B is also available, and you can join or view our website by the website link on the bottom of the page here. We have a patient storytelling program that works to elevate lived experiences and build awareness globally on hepatitis B and the impact of hepatitis B on those living with it. We have public health research that works to understand and document lived experiences associated with hepatitis B, and anti-discrimination efforts that work to raise awareness of the impact that hepatitis B can have on people, employment, and future opportunities. We have advocacy efforts as well, a hepatitis delta program where you can learn more about hepatitis delta and liver cancer. We have various coalitions working to expand the use of best practices in public health in addressing hepatitis B globally. You can find more information on the website at the bottom of the slide, and I encourage you to check that out as well as other resources there. So now I would like to turn it over to Dr. Philippa Easterbrook with the World Health Organization, who helped spearhead the effort on the hepatitis B guideline updates. You can also view the link by the QR code here to the guidelines directly, and I encourage you to be sure to check those out as we move into today's discussion. And Dr. Easterbrook, I will turn it over to you.
Thank you very much, Catherine. And can I just check that you can hear me well and that there's a full display of the screen? Great.
Yes, it looks great. Thank you.
So good morning, good afternoon, and good evening, everybody. I think this is a terrific opportunity to share with you in the community, from NGOs, from implementing partners, the key messages from the new WHO guidelines on prevention, diagnosis, and treatment of people with chronic hepatitis B infection. And on this first slide, you can see the front covers of the two main products, the policy brief and the full guidelines. And this is a QR code, so do please, I'll be sharing it again at the end of the talk, but highlighting all the key products that are on the website, the guidelines, the policy brief, the web story, and also a link to an article from last week in the Lancet Gastrohepatology, which highlights the key take-home messages from the new guidelines. So I think many of you will be aware that these guidelines were launched at the APASL conference on the 30th of March. And that was linked with an excellent community-led session on the guidelines. And right on cue, the cherry blossoms erupted in Kyoto the day after the guidelines launch, which I hope is a good omen. So to begin at the beginning, this is to remind you that we had guidelines from 2015, that's public health guidelines. And this slide summarizes the algorithm, and shaded in blue on the left were the categories of those who qualified for treatment. But there's an awful lot of white, and the white was really the deferring treatment and monitoring. And we're in a very different place now. And summarized in this table was the recommendations across the continuum of care, from staging, who to treat, first-line treatment, various monitoring strategies, and then also the prevention of mother-to-child transmission. And highlighted in red were some of the areas that we had highlighted, particularly in need of updating. And the main new areas that have been updated and with new recommendations are the first three rows: the staging, the who to treat, the first-line treatment, and also right at the bottom, the antiviral prophylaxis to prevent mother-to-child transmission. So I think many of you will be aware of both national guidelines as well as professional society guidelines. And this is to remind you that our guidelines, the WHO guidelines, particularly focus on low and middle income countries and adopting the public health approach with simplified and standardized approaches, rather than the individualized treatment approach with many different treatment options and scenarios that sometimes characterize the other professional society guidelines. We aim not to cover every issue, every topic, but the broad brush of the key management of hepatitis B. I think the other distinctive feature of our guidelines is really the comprehensive approach to evidence retrieval, doing surveys in the communities and healthcare workers, doing diagnostics and the antiviral landscaping, undertaking modeling, as well as systematic review. So this was a very comprehensive approach to evidence generation to inform the formulation of the recommendations. Well, these were the main topics we focused on, as I'd highlighted on the earlier slide, looking at non-invasive fibrosis assessment, who to treat, first-line treatment, prevention of mother-to-child transmission, some of the diagnostics innovations, and particularly around testing for Delta infection, and then approaches to simplifying service delivery. And I should say there were overall about 30 recommendations, of which more than half were updated or new recommendations. Well, this is to give you a sense for those as you dip into the full guidelines, which is quite a large document, but summarized in the policy brief. And every chapter, and there are 20 chapters, follows a standard format with the recommendations, the background, the summary of the evidence, and then in a shaded box, the rationale for the recommendation. So really the elevator pitch of why we recommended what we recommended. And then it finishes with each topic on implementation considerations for countries to put in place and adopt these recommendations. And then also, very importantly, research gaps. And it was divided into 3 sections: expanded treatment eligibility, the diagnostics, including Delta testing, service delivery, and monitoring. And then with each of these subsections, we had a series of chapters. And so to start with the first one, the expanded treatment eligibility, we had 6 relevant chapters here. I think first and foremost to really stress that center stage in the assessment of all persons with chronic hepatitis B or B surface antigen positive, we are strongly recommending the use of non-invasive tests in all patients, be it an APRI score or be it using transient elastography, if that's available. That we consider that every patient, and this applies to low and middle income settings, should be able to access at least the APRI score, that's using just the AST and a platelet count, widely available and low cost, so that everybody can have their liver disease staged. And why is this important? Well, because the new recommendation that where we define new thresholds for determining anyone with evidence of significant fibrosis. In the 2015 guidelines, we focused on the use of these tests to pick up cirrhosis. In these guidelines, we're moving to an earlier stage of disease and the use of these tests to pick this up, and with much lower thresholds. And this feeds in directly into the treatment recommendations. So who to treat. So center stage in these guidelines, we're recommending treatment for all adults and now adolescents, which is a new feature. That's those of 12 years and above with chronic hepatitis B. And of course, this will include pregnant and non-pregnant women and girls of reproductive age. And so there are 4 options for meeting treatment eligibility. And these can be and or. So you can meet one of these and you can meet all of these. And the first, and that relates to my earlier slide, is anyone with evidence of significant fibrosis based on an APRI score greater than 0.5 or using the ultrasound technique, transient elastography of greater than 7, or where there's evidence of cirrhosis, regardless of the Hep B DNA or ALT level. So you don't need to have anything else if you meet this criteria. Or in settings where there is availability of Hep B DNA, a Hep B DNA greater than 2,000. And this compares with a Hep B DNA of greater than 20,000 previously. And this is with an ALT level above the upper limit of normal. And we've given those levels that can be used in men and boys and those for women and girls. And for adolescents to have at least 2 that are above the upper limit of normal. Or simply the presence of a co-infection, such as HIV or hepatitis delta, a family history of liver cancer or cirrhosis, evidence of immune suppression, evidence of comorbidities like diabetes, metabolic associated steatotic liver disease, or extrahepatic manifestations. And then a final or, in those settings where there is no access to a Hep B DNA, persistently abnormal ALT levels. And this was a recommendation we had back in 2015. It's fair to say was not widely adopted. And this is the new algorithm on the right, with a comparison on the left. And this algorithm, which I hope is user-friendly, at least to the implementing partners and clinicians, is really starting out with assessment for treatment eligibility, 3 simple steps, and some general care measures about counseling, preparation for starting treatment, and preventative measures and screening other family members. And then the 4 options for meeting treatment eligibility, with now on the far right, very few who will fall into the category, or a much smaller proportion of those with persistently normal ALT and a Hep B DNA greater than less than 2,000. And then it gives the treatment options and also the monitoring. With the annual monitoring, which is really not changed from our 2015 recommendations. Main messages here, we're now including all age groups, the adults, the adolescents, and the pregnant women. This really does allow a common entry point for treatment. which will really simplify things. The same criteria across all those populations. And we intend and hope that this also means that many more pregnant and non-pregnant women and girls will be eligible for treatment for their own health. And so will already be on treatment when they become pregnant. But nevertheless, this complements the vision also for expanding eligibility for antiviral prophylaxis. And the 4 options for meeting treatment eligibility, we estimate based on modeling that this will now capture at least 50% of all Hep B surface antigen positive, probably 60 to 70% in the Asian region, compared to around 8 to 15% previously. And this is applicable to all settings, regardless of whether there is ready, limited, or no access to Hep B DNA assays. And we anticipate that the majority of those Hep B surface antigen positive will meet the criteria for treatment without the need for a Hep B DNA assay. Only one of the options requires this. Nevertheless, we don't want to de-emphasize the value of Hep B DNA, particularly when it comes for monitoring. And again, just to reiterate the critical importance of that first recommendation of those with significant fibrosis. And this is the subgroup that will benefit the greatest, have the greatest benefit in reducing liver cancer, cirrhosis, and mortality in treatment. And just to make you aware that this was all informed by 2 systematic reviews, well, several systematic reviews, modeling work, estimation of numbers needed to treat, and some really comprehensive values and preferences surveys in the community. The second or third key area of recommendations is on the antivirals. Previously, we recommended the 2 drugs with a high genetic barrier to resistance, tenofovir and entecavir. They remain as preferred regimens, but now for the first time, we're including as an additional option alternative regimens, dual therapy, if monotherapy, tenofovir monotherapy is not available. That's tenofovir with lamivudine or tenofovir FTC. And also the option of the use of entecavir or the use of TAF in persons with established osteoporosis or impaired kidney function, and also selectively in children and adolescents. And the evidence reviews that we did showed that TAF and versus TDF or TAF versus dual therapy had very similar effectiveness, with a little bit of a difference between TAF and TDF in risk of renal impairment, but the changes were really very small. And the main reason for including the dual therapy is to allow expansion of treatment in countries where there's sometimes very limited availability of tenofovir monotherapy, but we hope this will change in due course. Moving now to the prevention of mother-to-child transmission. So 2 key recommendations, one updated from 2020, which is in settings where Hep B DNA or E antigen is available, prophylaxis with tenofovir is recommended for those women with a Hep B DNA greater than 200,000 or a positive E antigen. That's a strong recommendation. But recognizing that in settings where neither Hep B DNA or E antigen is available, the option as a conditional recommendation of the use of prophylaxis in all Hep B surface antigen positive women. And prophylaxis can be offered from the 2nd trimester of pregnancy until at least delivery or after completion of the infant vaccinations series. And you can see here on the right, the algorithm, and with the 2 pink shaded boxes are the 2 where maternal prophylaxis can be offered, either on the basis of the Hep B DNA or in the absence of Hep B DNA to all Hep B positive mothers. And very importantly, and I think this has been a source of some confusion, we really want the women to be also assessed for eligibility for long-term treatment for their own health. So we've got both the criteria for the prophylaxis, but I've also put there the criteria for the treatment eligibility. And clearly, this is something on the implementation side that will be need quite a bit of work in countries. So I think the rationale for the Hep B DNA one was based on long-standing evidence of really a marked impact on prevention of mother-to-child transmission, and that really there is no evidence of transmission when the viral load is less than 200,000. But acknowledging that in many settings there was very limited access to Hep B DNA or E antigen, and so women were getting nothing for the prevention of mother-to-child transmission. But the support for this recommendation was based largely on a pragmatic approach supported by modeling. There were no studies that have been done so far to examine the clinical impact and the feasibility. We know that the birth dose remains the most important intervention to prevent mother-to-child transmission. We also recognize that this universal prophylaxis approach may only be cost-effective in some countries, and the relative cost-effectiveness of using the Hep B DNA or universal will depend on the relative costs of testing and treatment. Moving now to the Hep B DNA, I'll skip through this fairly quickly, just to make you aware that, as with the Hep C guidelines 2 years ago, we are also given the option of using a point-of-care Hep B DNA instrument as an alternative to lab-based Hep B DNA to really promote access to assessing for eligibility and monitoring treatment response. And just as with Hep C, we're also promoting the reflex Hep B DNA testing as well as an efficient way to speed up the uptake of viral load testing and treatment. And these have been shown to really be useful tools to promote access. For the first time, we included recommendations on testing for Delta, that very important co-infection that results in so much Hep B-related morbidity and mortality and progression to cirrhosis and liver cancer. And so the option of either a universal testing approach, so all Hep B surface antigen being automatically offered testing for Delta, or recognizing that there will be settings where this approach is not feasible because of limited laboratory capacity or resources, and ensuring that testing for Delta is given priority in specific populations likely to be at greatest risk of having Delta infection. So those from Delta endemic countries, those with advanced disease or on treatment, and those in populations at higher risk hemodialysis recipients, those who inject drugs, and men who have sex with men. And recognizing there's a limited evidence base to support these different approaches, but the risk-based approach alone seeming not to have achieving sufficient coverage. And the approach to Delta testing is with the antibody followed by the NAT and molecular tests to confirm viremic infection. And again, we are really promoting the reflex testing as now a lab efficient way of ensuring that many more people get Delta testing if they're Hep B surface antigen positive. So moving now and finishing off with the Hep B service delivery, there was insufficient evidence at the moment to formulate formal recommendations on decentralization, integration, task sharing, as we did for hepatitis C. What we do have is some good practice principles or approaches that really need to be embedded in every program, in every facility. And these include strategies to strengthen linkage from testing to care and treatment, use of dry blood spots, for example, peer support, and very importantly, as I'll show in the next slide, the need for strategies for long-term adherence support, strategies to promote retention in care. These are particular weak points in the care cascade for hepatitis B, and increasingly to move towards opportunities for integration, decentralization, and task sharing. And the table on the right shows the differentiated care approach for the exploring decentralization. So those who are clinically well and stable on treatment are the ones that can be managed at a lower level facility. Those with more advanced disease are reserved for the facility-based care, and the critical importance of the community engagement. In terms of hepatitis B service delivery, we have a range of different models. It's fair to say that the majority of them remain largely hospital-based, although that's beginning to change. But something that really is very striking is the high attrition across the cascade of care. From those who initially are referred for care, those who are retained in care, it's less than 35%. And those who have viral suppression, again, it's less than a quarter. And this is apparent, be it in primary care or hospital-based models. So really a major flag of what is important going forward, the retention in care and the adherence, and much to be learned from HIV about all the support strategies that were used in HIV care. And this will be a critical role of the community going forward. Implementation priorities, we need to substantially scale up testing and case finding. That we're really supporting countries that are going to be the first wave to adopt these new guidelines. I think we already have 12 who are in advanced stage now of adopting these new recommendations. And then in terms of the community, the critical importance of widespread education and awareness raising campaigns among the community, as well as healthcare workers, formal training of healthcare workers, and pursuing the opportunities for hepatitis B meds and diagnostic price reductions. I think this is just not to go through in detail, but to flag that each chapter has these implementation considerations. I've flagged here the ones for the who to treat and the box on key items in the initial assessment, and similarly for the PMTCT, issues as the need to continue to promote the coverage of timely birth dose, the need to promote the integrated testing for hepatitis B, HIV, syphilis in pregnant women, and the need for integrated service delivery models for HIV, hepatitis B, and syphilis for triple elimination. And these are all the topics which have a research agenda. And huge thanks to the many excellent members of our guidelines group, our pediatric subgroup, our Delta subgroup, and the WHO steering committee. And just to leave you with the QR code once more. Thank you.
Thank you so much, Dr. Easterbrook, for that presentation and great overview of the guidelines. I think there's a lot to digest, and we already have really good questions in the chat box, but I'm going to turn first to our panel to provide their insights, and then we'll go into question and answer from the audience members. So those in the audience, please be sure to put in questions that you might have for any of the panelists today. So Dr. Easterbrook will be joining our panel, Dr. Wendy Spearman, head of the Division of Hepatology at the University of Cape Town, Adesuwa Oni, an advocate for hepatitis B at Rise Against Hepatitis Global Initiative, Dr. Saeed Hamid, the Director of Clinical Trials Unit at the Aga Khan University, and Getan Kwahara Pam, the Community and Policy Program Manager at Treat Asia in Thailand. So we have a great representation from both civil society. Dr. Spearman and Dr. Hamid were both involved in the development of the guidelines, and Dr. Easterbrook as well, leading the guideline effort as well. So I'd like to start just with the panelists. If you could introduce yourself and briefly tell us a little bit about your affiliation and the communities that you serve, and those that specifically work in clinical and then also community, how these guidelines might impact your communities as well. So I'll start with Dr. Hamid, if you don't mind with that.
Thank you, Catherine, and thank you for the kind invitation. You've heard the comprehensive talk from Philippa already. So, I'm a physician at the Aga Khan University in Karachi, Pakistan, and I treat patients with both hepatitis B and hepatitis C. Now, as people may know, uh, Pakistan is well known for its highest global burden of hepatitis C in the world. And that is what our focus has been over the last few years, and that is the elimination of hepatitis C. But I guess what these guidelines will do will refocus our attention and the attention of the program, the government programs, and so on hepatitis B as well. If the prevalence for hepatitis C is around 7%, the prevalence for hepatitis B surface antigen positivity in our population is about 2.5%. Not a small number when we consider that we are a population now of about 230 million people. So these guidelines will most definitely, first of all, stimulate or re-stimulate the interest that we have a substantial burden of disease for hepatitis B as well. In addition, and really quite as a personal point of satisfaction, is the fact that there is focus on hepatitis delta, because we have a huge pocket of hepatitis delta in Pakistan, and those are really neglected communities because, as you know, it's an orphan disease right now. We don't have treatments for it, at least approved treatments. And the disease severity is such that it lands people in trouble very, very quickly. The testing of Delta, what it will do is, I'm sure, it will give us the correct epidemiological data, not just from Pakistan, but from many parts of the world. And the hope is that that will further accelerate drug development for hepatitis Delta. And therefore be able to serve these communities. The current scenario, if I just spend a couple of minutes on hepatitis B cascade of care, is really rather poor, because, as I said, the major focus is on C. So people do get tested, but the linkage to care is poor, and that is something that we need to consider. And why is the linkage to care poor? Because diagnostics, particularly the DNA testing, is expensive. And also the commitment to treatment, which is in many cases, as we know, can be lifelong, is also a big task for not just the government programs, but also for the NGOs, community-based organizations that run these programs within the country. So typically what happens is that people get a DNA test from somewhere, they get a treatment course of treatment of TDF or entecavir for a year, and then they are left alone to fend for themselves in terms of treatment. And that is where there's a lot of drop-off in terms of the continuity of care. So I think that is our biggest challenge. And that, I hope, will these guidelines will stimulate a lot of discussion on how we maneuver our own national guidelines so that these communities can be well treated and can continue. The last point that I need to make is that the vaccination, the adult catch-up vaccination for hepatitis B, is doing well in our country. We've got about maybe an 80% coverage or something like that. The programs love to do it because they can show their numbers and they can get all the thanks and so on, appreciation for that. What we miss out is the PMTCT, and that is now currently the biggest driver for transmission, as far as we can understand it, in our country. So I'm glad that the focus on PMTCT has been sharpened, and we are putting emphasis on the birth dose vaccination, which hopefully will be starting in a reasonable manner very soon, because as we understand it, Gavi is now well prepared to support these efforts. In addition, I think what we need, and Philippa stressed on this, is antiviral prophylaxis, which I think is extremely important. It can be easily given because the TDF is is very cheap, easily available, and even a 6-month course, 3 months before pregnancy and 3 months post delivery, let's say as a minimum, would be a very, very cheap way of doing this and doing this effectively. So those are some of the points, some of the implementation considerations that I think we need to be aware of in a country like Pakistan. Over to you.
Thank you so much. I think the themes that you mentioned are very relevant, really globally, for us to be thinking about, particularly thinking about the cascade of care and starting with diagnosis. I think there was a recent Lancet article that was really just highlighting the clear gaps that we have in terms of working towards the elimination goals from WHO. Gitin, I'd like to hear from you if you don't mind sharing about your context and how these guidelines might be applicable from your perspective.
Thank you very much, Catherine. Philippa and Dr. Hamid has already laid out quite a bit of important aspects of both these guidelines and also in implementation considerations. I also would like to mention that there was a progress report for the audience. It is not just these guidelines, but also there was a progress report on viral hepatitis responses. You can find this in the WHO guidelines. So if someone can quickly look up and share the link here, it would be really good. So it gives a very good picture of where we are in terms of new disease estimates, in terms of availability of products, pricing, and also, other considerations around regional breakdown of infections and prevalence and mortality. So that would be a very good document to look alongside these recommendations also. By the way, my name is Gitin. I work with Treat Asia, which is a program of AMFAR, and I'm based in Bangkok, Thailand. I've been a part of the guidelines development group for this hepatitis B guidelines and also for other hepatitis C related WHO guidelines. Just to give a background, the new estimates on the progress report you would find as 254 million chronic cases against the earlier estimate of 296 million cases. What is good is new infection is going down compared from the earlier 1.5 million to around 1.23 million. So new infections has been going down as reported in that progress report. However, the death has gone up considerably. So from around 0.82 million, it's around 1.1 million in this latest report. So we're losing a lot of people as we progress, from one guideline to another. At the same time, as we progress towards elimination in our own national strategies and national programs. As Dr. Hamid mentioned, the diagnosis is quite low. We were at 10%, although we were targeting at 30% in 2020, but now we are at around 13.4% diagnosed hepatitis B, of which only 2.6% has been treated so far. So all this information you will get in this new progress report. Now, Philippa had mentioned that we anticipate this new guidelines to include approximately more or less around 50% of the chronic cases compared to the earlier 10 to 15% that we were looking at. So this guideline was shaped in a way as to how do we include more people than who do we exclude. Like the concept in the preparation and the development of the recommendations were completely different from the 2015 guidelines. We are aiming at 60% by diagnosed and 50% of that to be treated by 2025. The report of that would be only available in 2027. I'm just looking forward a bit. And by that time, we would be left with, the 90 and the 65%, all that global, both viral hepatitis B and C related elimination targets, we'd be left with only 3 years. At this point, we are not doing very good or not close to the global elimination targets. We anticipate absolutely that this new guidelines will assist, number one, for the national governments to relook at their own national guidelines. How quickly we do, and the faster we do, the quicker we do, absolutely, it's going to make a lot of difference to a lot of people who will be bringing to the cascade of screening, the proper diagnosis, and to be on treatment. Now, there are a lot of patient groups, a lot of community groups, a lot of research organizations who can actually assist in making that happen. But the national governments would have to step up to make sure that these guidelines, to the best possible way, is adapted and implemented in their own national settings. There has been a question in that chat box as to why not treat, in the question and answer box, as to why not treat everyone who is surface antigen positive. If you look at these guidelines in chapter 5, there is a narrative text. It's not part of the recommendation, but there is a narrative text which says that, if the person who is living with hepatitis B and the physician who is providing care to the person, discusses and understands the pros and cons of offering treatment or being on treatment, long-term treatment, understanding everything, then that could be considered. So that's a part of a narrative text, but not a part of the actual guidelines, actual recommendations. So those are some of the things which I also would want people to look at. The other things is around, the medication. In terms of tenofovir, for example, is extremely cheap at this point, which Dr. Hamid hinted at. It's around $2.4 per month. So you're looking at around $24 to treat, especially for people from the US. I see in the US FDA Orange Book that there are a lot of generic companies, not only from India, but from Israel and others, who have their products registered and supplied in the US. So maybe those are also, of course, I understand some of the intricacies in the US around, insurance and who can be provided what, all those things are there. But then I'm just citing that there are other, I'm sure people are also aware that there are a lot of companies who are offering have their products registered and available in the United States. So I think overall, the new updated guidelines is definitely a step forward. If we can include that 50%, it's a remarkable way to go forward. But it has to be adapted by the national governments in Africa, in Asia, in Latin America, in Europe. Everywhere it needs, wherever it's applicable in LMIC, especially, it has to be adapted and adopted. One of the challenges specifically, and I've raised this in different platforms on PMT-CT, is non-availability of RDT, HBs e-antigen RDTs. So we don't have a WHO pre-qualified. So that's specifically needed more for PMT-CT. But as in most of the countries, as we see, do not have DNA testing facilities or not have enough DNA testing facilities, either at all or no. So in those cases, e-antigen tests are required. But at this point, no WHO pre-qualified e-antigen test as RDTs are available. So that would be one of the key components if we have to take forward PMT-CT in a way. There is also a recommendation which Philippa showed, in case if both DNA and e-antigen is not available, then offer prophylaxis to all pregnant women who are surface antigen positive. That option obviously is also there. But absolutely, these guidelines and recommendations are a positive way forward. We are not yet there as in HIV or hepatitis C to treat everybody with a chronic infection, but we'll get there surely. Thanks, Catherine.
Thank you so much, Ketan, for your perspective. Want to turn it over to Dr. Spearman to get your feedback, particularly from South Africa. I know sometimes getting reference treatment accessibility, but I know sometimes, particularly in the context of the Afro region, treatment accessibility is something that's quite challenging. And I know it was mentioned in one of our questions and in the chat box as well. If you could maybe speak to that.
Thanks, Catherine, and hello to everyone. So, if I look after patients from all tiers of hepatitis B, from those who have hepatitis B surface antigen normal ALTs and no underlying liver disease to those with advanced cirrhosis. So we see the whole spectrum at our liver clinic. And together with my colleague Mark Sondrup, we also run the Project ECHO program of viral hepatitis within sub-Saharan Africa. So we reach out in terms of actually helping to improve delivery of care across Africa in terms of helping to manage complex cases as a team. But I think if we look at that global hepatitis report, as Gideon has mentioned, if we look at the burden of disease within WHO Africa, we're looking at nearly 65 million. And of those, only 0.2% have been diagnosed. Sorry, 4% have been diagnosed and 0.2% actually treated. So we're really not actually achieving the goals. And we're very far from achieving goals, even the interim goals of 2025. So I think if we look at these new guidelines, they really help to demystify the management of hepatitis B. I think if we look at the sort of old concept of looking at those different phases of chronic infection, there's 5 phases, they're really quite overwhelming, both for undergraduates, postgraduates at primary healthcare level, and even physicians. And I think these new guidelines help one to actually understand, and particularly if we look at WHO Africa region, that big concern about these young individuals presenting with multifocal liver cancer in their 20s, 30s, and having really only survival of about 2.5 to 3 months. And so what is really, I think, is going to make a big impact is the fact that we are picking up and enabling treatment of those who have advanced fibrosis with really very easily implementable non-invasive tests, so the APRI score, and that's been lowered, has been shown that so if you're more than 0.5, you access treatment. It doesn't matter what your ALT or those barriers to actually initiating therapy, particularly in those that you might have risk of developing HCC. The other thing I think that's very important is that these guidelines are fantastic, but we need to, if we're going to actually have any effect on the numbers diagnosed and numbers treated, we, as Philip has clearly said and others have said, we need to decentralize it, and we need to move that out of liver clinics, out of specialized clinics to primary healthcare. And that's going to really require that access to that point of care testing. And I think if one's looking at sort of doing it stepwise, we've shown that you don't need a hepatitis B DNA level to initiate therapy. You can do it just with surface antigen. So I think really the first place is really just to get that point of care surface antigen testing out into that primary healthcare. And we need to be innovative how we can actually approach, because at the moment diagnostics are costing more than treatment. And so unless we address that sort of real barrier of diagnostics, we're not going to make any inroads into this burden of disease. So I think as a region, we need to look at innovative ways how we actually can address that. I think the big thing we've seen, and we look at starting individuals, we'll be looking at increasing by 50%, the sustainability of having tenofovir. And we know across Africa, the access to monotherapy can actually be difficult. And so I think this recommendation that you can use combination therapy, tenofovir and tracitobin or tenofovir lamivudine, will make a great, enable people to actually initiate therapy. And I think there was somebody mentioned in the chat that they've already been doing that. So I think that's very, very important. And that will enable, I think, integration more into the HIV programs, where you're not having separate tenofovir for this, Truvada for that. And so particularly with increased use of PrEP, I think this is going to enable us to actually put more people on treatment. But then this retention of care is going to be extremely important. I mean, we know that we've made great strides in HIV, particularly in Africa, in achieving those 90-90-90 goals. But we know in real life, the actual disengagement with treatment is really a big problem. And that is something that we really need to actually address. And I think particularly if we're integrating, that's going to have potential positive impact both on HIV programs and integrated hepatitis B programs with that. I think that's going to be really very, very important. And then I think this, at the same time, we need to look at really improving education, both of the public, both of healthcare workers, policymakers, because I think this is going to need to require at all levels, and particularly demand from people living with hepatitis B, that they actually are screened, their families are screened, and they get access to therapy. But I think this is going to play a great role in actually enabling us actually to embark on this implementation, but it will require a lot of work from all of us to take it up. And it's going to require significant infrastructure when we all talk about integrating with HIV services, but we need to realize that actually requires that we look at increasing the numbers by 50%. So if you look in Africa, another 30 million people being treated, you can't just say you're going to integrate. One needs to provide appropriate support for programs that, particularly the HIV programs that we're integrating with. And so that's going to require really close interaction with our policymakers, departments of health. But I think this is going to really go a long way to actually changing and increasing access to care. And I think these guidelines are really extremely easy to follow. The other big positive thing is the not relying on an e-antigen or DNA to initiate therapy to prevent mother-to-child transmission. And I think the other thing that I think was really quite innovative in those guidelines where if you have a young woman who's planning to have, a couple of children within the next 5 years, in discussion with the woman, you can actually decide, are you going to continue that therapy for the next 5 years, even though they themselves might not require therapy in their own right. And then I think, as Philippa very carefully said, very, very important that the mother's assessed for treatment in her own right. And I think that once again raises the awareness that hepatitis B is a chronic condition that needs ongoing care. Thanks, Catherine.
Thank you so much, Dr. Spearman. And I'm noticing just from the chat, there's a lot of clinical focused questions. So want to also echo the need for decentralized care or decentralized management of hepatitis B. So outside of the specialty clinics, and also plug the wonderful ECHO that you guys run out of Cape Town as a great resource for getting a lot of these clinical typed questions answered around hepatitis B, many around when to start, stop treatment, things like that. So definitely join the ECHO, and we'll put a link in the chat as well for that, because really pushing the ECHO model is great to decentralize management and care of hepatitis B. So now I'd like to hear from Adesua about the on-the-ground community side and the implication for these guidelines, and how you guys are working to really address some of the cascade of care and barriers to hepatitis B in your communities. And I know they're doing a lot of work on awareness, which was also mentioned by Dr. Spearman as something essential for reaching elimination goals and implementing these guidelines. Over to you.
Thank you, Catherine. Thank you, everyone. Can you hear me? Can you hear
We
me?
can. Yes.
Okay. Yes, I want to first of all thank Dr. Philippa and her team for the great work which they have done to actually put together this guideline. Of course, by broadening this eligibility treatment criteria, more people that are in the hepatitis B, affected by hepatitis B, are actually going to be involved in treatment right now. Yes, and this will also help in reducing the development of advanced liver diseases such as the cirrhosis and the HCC. So we're actually grateful for this guideline too. And also the inclusion of the PMTCC also in this guideline actually is a great one. Thumbs up to the team once again, because I believe this will actually the potential means of reducing transmission of these diseases. So the guideline is a great one. Now, from the civil society perspective, yes, it's a very good thing to implement guidelines such as this, or to bring up guidelines in this. But the most important thing here is the implementation, because we have a lot of guidelines, strategies on ground, national strategies, policies, but the implementation is the major challenge here. And I would like to say that the civil society will actually play a crucial role in the implementation of this guideline. Yes, they could start by advocating for the adoption of these guidelines at all levels, starting from the local level, then moving to the state level, and then to the national level. By so doing, this the Ministry of Health, the healthcare professionals will be aware of these updated guidelines, because most of them are still not aware of these guidelines. So it is our duty as the CSO to bring this knowledge to them. And also not just stopping at that adoption, we should also look how we can actually monitor the implementation of this guideline. Yes, we should ensure that the healthcare facilities are effectively implementing the new eligibility criteria and ensuring that treatment is reaching those who actually needs this treatment. And also the civil society, since we are the ones with the boots on the ground, we're the ones actually doing the job on ground, we should also try to provide support services to people living with hepatitis B, like counseling them, as Dr. Wendy rightly mentioned. We need to do a lot of awareness. We need to raise this hepatitis B awareness at all levels, in all corners. Really need to do this. We could also help people living with hepatitis B in assisting them in navigating the healthcare system to actually access treatment and care. These are many more things the civil society could do, but there are a lot of challenges, which I would really want to mention again. I know Dr. Hamid also mentioned it, and even Dr. Gibson mentioned it, but I would like to still stress it again. These challenges existed even before these new guidelines actually came up. And with these new guidelines and having over 50% of people, as mentioned by the guidelines, involved that will be eligible for treatment, meaning that these challenges is going to be on the increased side. Challenges such as the limited diagnostic testing. We really need to look into this. If we're having more people to be treated, then this challenge needs to be addressed so that these people can actually have access to diagnostic testing and treatment. Then the second challenge is the availability of the antiviral prophylaxis. Now, from the new updated guidelines, almost all the women, if not all, that are testing positive for hepatitis B surface antigen are to be treated, right? Starting from the second trimester down to the last series of their infant hepatitis B vaccination. So we need more of this antiviral prophylaxis drugs available. And in my country here, that is a big challenge. I heard Dr. Wendy mentioning that the diagnostic aspect is more expensive than the medication. But over here, both are on the high side. We cannot even afford it. In my own community here, you cannot even have antiviral load tests done. Viral load tests done. You can't have it here. It has to be, the sample will be taken here and then sent to the state capital to get this test.
Thank you so much, Adesua. And just for context, she's coming to us from Nigeria as well, where she mentioned really key challenges in accessing diagnostics and treatment. And I also think your point is well taken that we as civil society have a role to play in really making sure that these guidelines are implemented and advocated for at local, state, and national levels, so we can really make sure that the treatment expansion is actually seen on the ground for those that need it most. Dr. Easterbrook, I think you had mentioned being able to address many of the questions in the chat through your responses and maybe some reflection on what the panelists have also mentioned as challenges and also considerations for implementation.
Sure. Let me just return to the screen with the questions. And I think I'd flagged there were questions about the HBIG, dual therapy, partner testing, discontinuing treatment, infant vaccination, the viral load less than 2,000, and a couple of patient-specific clinical questions. So I'll just touch on them briefly. And I think to have Wendy here, I believe Syed's not with us anymore, to reinforce or pick up on some of those I may have missed. And I've answered a few in the Q&A. I'll turn to those next. So I think on the issue of HBIG, and I'm glad that question has been asked, because this is often a common question, a common source of confusion. As many of you will know, particularly in high-income countries, HBIG is often used as one of the key interventions for prevention of mother-to-child transmission, particularly in higher risk populations. This is something that is not formally recommended by WHO. We recognize it's there in the kind of the set of tools that can be used in the antenatal clinic setting. but it is costly. It is not widely available. And particularly in low and middle income countries, we are, of course, promoting the main widely available and low-cost interventions, which is the infant vaccination, and now, particularly for sub-Saharan Africa, the implementation of the birth dose. It's so important to keep our eye on the prize of that absolutely critical intervention we want to promote, and with the antiviral prophylaxis. So I think it's not that we're that HBIG is not a good intervention, but it is, for the public health approach and for low and middle income countries, it is not the center stage. I think it was very good to see some comments on the chat of the value added by the inclusion of the dual therapy. I think some people had questioned, I think highly Michael, why? And it is because, for one reason or another, that tenofovir monotherapy is often not registered or available in many countries. Clearly, that needs to change and it needs to be prioritized for registration. But given the availability through PrEP programs and through ARV programs where there's existing procurement and supply chain, dual therapy is often more available in some countries. And indeed, as one of the commentators said, we're doing it, we're widely using it. And this gives a legitimacy and rationale. So I think it's another option where access to tenofovir monotherapy is a limitation. I think the issue of partner testing and vaccination, I'm very glad that's come up too. This is something we recommended back in 2017 in our testing guidelines. We want, of course, all offspring, all children of Hep B surface antigen positive parents, but also family members and sexual partners to be tested. And that's not a recommendation that's been widely adopted, and it should be, because protecting those family members is extremely important, and vaccinating those who are negative. So I think I just want to reinforce that. It's there in the algorithm as one of the core interventions. And so that's good to reinforce. Discontinuing treatment, that was something we had in the 2015 guidelines. We've carried it over, but just refreshed and updated. We see in the public health approach and in low and middle income countries, very, very, very few people will qualify for discontinuing treatment. This really is a lifelong treatment in the vast majority, and certainly no one with cirrhosis or significant fibrosis should ever discontinue treatment. So the relentless focus in the implementation is on adhering to therapy and retention in care and lifelong treatment. And there are spelled out in that chapter some of the situations and scenarios for that individual decision making that's available. I think the viral load less than 2,000, I think the question had been asked, and I think it was referring to a particular case with normal liver function. That is the subgroup that we're saying, not just the viral load less than 2,000, but persistently normal ALT. And if you look at all the natural history studies, that group has a very low risk of progression or development of clinical events. Fair to say it's not zero. It's not zero. And hopefully, as things move forward with biomarkers that are able to identify the subgroup of that group who may benefit from treatment. But overall, in that public health approach, that group is at low risk of progression. And as Gitten had highlighted, we've got a remarks section, which allows, as should always happen, the dialogue between patient and their physician about whether it is the right decision for them to initiate on treatment on a case-by-case basis. I think I'll stop there. Actually, there was just one other one of somebody saying, They've been on treatment, they've had a suppressed viral load, and then it was detectable. I mean, Wendy can comment best, but I think the question was asked about resistance. I think the reassuring thing we have, and this is different from the situation in the HIV world, is resistance is extremely low with these very effective drugs with high genetic barrier to resistance. There's been quite a few long-term follow-up studies showing very low rates of resistance, particularly with tenofovir. So it's possible to have blips and obviously to ensure that adherence is optimal, but to provide that reassurance. And I'll hand over to Wendy to pick up on some of the other points that I haven't covered. Thanks.
Thanks, Philippa. So, I mean, I think in terms of the viral load blipping up, and I mean, we've shown in these guidelines that we are not dependent on a DNA to initiate therapy. But I think we must realize that if we're going to provide appropriate care for our patients long-term, we need to have that access to being able to monitor DNA. And I think we need to collectively actually really work on getting the cost of those hepatitis B DNA PCRs down. I mean, at the moment, they're looking at about $8. And still, I think within Africa, that's going to be too expensive. And so we do need access to that. I think in terms, as Philippa said, the chance of developing resistance to tenofovir is very, very small. And you're only going to see that. And the first thing would be to see, are you adherent? Are you taking it intermittently? Are you taking it at different times? And so really, I think one shouldn't be concerned about resistance, but that is the benefit of actually looking at a DNA level on a regular basis, sort of 6 monthly to annually, to see what the trend is. Just to remember, if you're starting at a very high viral load of tenofovir, it might take more than a year to actually come down completely and be suppressed, but you shouldn't be having ups and downs. It should be a slow, steady decline. Just in terms of the HBIG, I think one of also the benefits now in these new guidelines is that we're starting the tenofovir prophylaxis in the 2nd trimester. So we're starting it earlier. I think if you screen somebody in the 1st trimester, I mean, obviously it's not in the guidelines and they have a very high viral load, there's no contraindication to actually starting the tenofovir as soon as you make that diagnosis, even if they don't require treatment in their own right. So I think we've shown from the HIV data that tenofovir is entirely safe throughout pregnancy, safe for the baby, and so there should be no concerns about it. And I think that's something that also we need to really stress with our patients when they become pregnant, that they mustn't stop the tenofovir. We've had a few of those where there's been a concern from the mother's side about the safety of tenofovir. So really, actually, to really engage in these discussions when you first meet a young woman who's going to be planning to have a pregnancy, or not planning but becomes pregnant. I think those are discussions that we need to have up front. Thanks. I think there was a question there from Mark.
About Delta.
The reflex Delta testing. So, I mean, I think if we just look within Africa, there's a potential problem that the PCR testing is not going to detect the hepatitis B genotypes 5 to 8 or genotype 1A. I think it is important that we actually know what our underlying epidemiology is. And because if we don't know what the prevalence of an infection is, it makes it very difficult for us to actually then address the need to have therapy. But as you quite rightly said, the cost of the bulevirtide is really going to be beyond what people can afford. But I think unless you know the data, we have no data then to actually have a bargaining power to try and bring those prices down. There was another question, I think, on where are we with curing hepatitis B. I mean, certainly there are now a number of trials on functional cure ongoing, and that really brings into this our ability to access trials within low middle income countries. If we look at the protocols that are required to actually manage a functional cure, they're really quite they require a lot of work, a lot of monitoring, and I think we need to be upfront that we need to be engaging with pharma and industry, that they need to provide the adequate support to actually run these trials, because you need to follow them up very carefully. But it would be a real crime if within Africa and other regions where there's a high prevalence that we don't have access to these trials. It's going to be combination therapy. I think it's not going to necessarily be easy therapy to take. And I think once again, the cost is going to be quite significant. So particularly in terms of being functional cures, we really want to be able to get our patients onto these trials. And that's going to require as a community that we actually really see how we can engage with farmers so they can provide the adequate support to run these trials. Thanks.
Thank you. And we have a couple of questions as well related to co-infections. Philippa or Wendy, either of you may be able to answer that and considerations for treatment for hepatitis B and those with co-infections.
I think this was referring to hepatitis C, but the reason why that third option of comorbidities, co-infections, is regardless of your APRI-score, regardless of your Hep B DNA or ALT, that having a co-infection alone would qualify you for treatment. And that was a quest to simplify. And very importantly, the family history of liver cancer and cirrhosis. Obviously, in many settings, the history of that is often not necessarily reliable. But just to be clear that if you fulfill any of these criteria, it's without the need to have a Hep B DNA ALT level. So that's on that one. And then just to pick up on two other points, one was just to reinforce on the Delta infection and Mark's comments about what about promoting testing in the absence of effective treatment. And I think Wendy may have covered this, but it was cutting out every so often, and so others may not have heard, that we felt this was an important step forward to have a more systematic approach to case finding, because it's very important that these individuals who have such rapid progression are being monitored more closely, and particularly that the Hep C, the hepatocellular carcinoma surveillance is really in place, because those are at particularly high risk, and the importance of very early intervention and diagnosis, and to have a register, to have a national register or within facilities, so that as and when new treatments become available, that those individuals have already been readily diagnosed. I wanted to just pick up on one of the service delivery questions, because I think some were viewing the proposal of a move towards integration as the HIV services swallowing up the hepatitis B. And I think it's more nuanced in that it's intended to potential integration or positioning of hepatitis B care within primary care for those who are clinically stable and appropriate, and the value of using the HIV infrastructure where appropriate. And indeed, we had a great project in Uganda called the 2-for-1 project, which was using the HIV infrastructure on 1 day a week, because you have staff who are experienced with adherence support, retaining people in care, the labs, the pharmacies. So aside a day a week or part of a day a week that could be used. And we're very keen, and I'd be interested to hear from any of you who are enthusiastic about exploring this option in your countries, and to have a demonstration project to show or demonstrate ability. And then finally, somebody had asked about, can we have laws? Can we have laws to make sure countries implement the guidelines? And I'm afraid guidelines are just that. Guidelines are a guide. And sometimes countries adopt, cut and paste the full guideline and all the recommendations, and sometimes they adapt it for their context. And I think what we're most keen to happen next is for as many countries as possible. And I think I have now 12, 14 on my list from both Africa and Asia that are already moved on new Hep B guidelines. And that is exactly what we want to see. And we want to see you as champions to really support developing new guidelines and then a bunch of implementation. Thanks.
Thank you so
There's a
much, Philippa. Oh, go ahead,
There's
Wendy.
a question, Catherine, on what are the side effects of long-term TLD, so tenofovir, lamivudine, and I think obviously the concerns is if you have underlying renal impairment or you have severe osteoporosis, and then importantly, the tenofovir is going to be problematic. I don't think there's been significant concern long-term that you're going to run into trouble with that, particularly, but I think in terms of your HIV, hepatitis B co-infected, your risk of renal complications are higher just because of the underlying HIV. So there we have the access then to the tenofovir alafenamide, and that's included in the guidelines. I think the important thing to remember, if you're HIV, hepatitis B co-infected and you're changing your HIV treatment for whatever reason, that you still need to continue dual therapy for the hepatitis B. So it would not be, if there was renal impairment, it would be not enough to switch to tenofovir for abacavir and just continue on lamivudine. You need another agent. I think that's really quite important. The other thing is often not realized is that in terms of disengagement from therapy or interruptions in therapy, the hepatitis B breaks through long before the HIV. And so that's another reason why it's quite important to be able to monitor HBV DNA levels. Thanks.
Thank you. There's a question about treatment accessibility and treatment access not trickling down to the local level. One individual would like to know, what at the WHO and local levels is doing to drive the message to try to work towards access to medication, particularly tenofovir.
So you're talking pricing or both? You just cut out.
Sorry, I think maybe Philippa, your network might be a little unstable.
I think so. I think the UK obviously has problems with its bandwidth. I'm just going to switch off my camera in the question.
Sure. Sure.
Move the reception. Yes, so this is about all aspects of access to the meds. Was that the question?
Correct.
I mean, I think tenofovir, we have a global access price of $30 a year. And really, most of the highly affected countries, there is no reason why your country should not be accessing at that level. And so I would encourage you all, and we actually were just discussing about with our CHAI colleagues about doing a global webinar to really make it very clear how countries go about ensuring they get access to that global access price. There's a nice toolkit on the CHAI website, and Gitin and others will be sort of well aware of that. So I would see that as first and foremost, get access to $30 a year. I think the issue of the obviously public health programs that cover the drugs and the diagnostics, that's well and good, but we recognize that in many settings it's still out of pocket access at the global price, while we continue to push governments to expand that core coverage of the diagnostics and the testing. The Hep B surface antigen is between $0.50 and $1 per test for around, again, no more than a couple of dollars. So that initial key step should be very low cost, and then it's the $30 a year. Interestingly, China's managed to get the cost down even lower with their tenofovir pricing, and so we may yet see further reductions. But I think it's at least get that global access price, because we saw from the recent progress report that some countries are paying way too much, and there is no reason for that.
Thank you. And another quick question before we get to the last one, related to rapid diagnostics, a Delta rapid diagnostic kit, if there's any updates for that, and also for hepatitis B to do Delta and HPV at the same time, if there's any updates on
well,
that.
I think the recent hepatitis. Sure, I can just quickly comment on that, and maybe sort of Wendy or Getin can add. I think at the recent World Hepatitis Summit just held last week, what was quite exciting is there were 3 countries that are now developing, it's still in development stage, of a twin Hep surface antigen and Delta antibody test. Now, clearly, these need to be assessed, have their diagnostic accuracy assessed. I think this was very promising, because that's probably the main gap we had highlighted in these guidelines. We need a rapid diagnostic test, and we also need gold standard molecular tests and gold standard lab serology tests as well. But this is, and I think this is where promoting testing, this is the sort of thing that galvanizes then companies to invest in the development of these more accessible tests.
Thank you. And just the last question for our panelists, what is your next step in working towards the adoption of these guidelines and the implementation in your various roles and capacities? Maybe Getin, if you could start us off with that.
Yeah, just before getting into that, Catherine, a quick note for everyone. As Philippa has also mentioned, tenofovir is currently a medication which is off patent, and it's 2.4x works. So you would get approximately at $30 per person per year. That's a global access pricing, and you should get, any country, any national program should get it. Anybody who's paying beyond that should get in touch with Hepatitis B Foundation or WHO, your country offices, WHO country offices, and see how best we all could assist you in making sure that you get that price. The other thing is around the diagnostics. If you recall, the GeneXpert cartridges for TB was dropped to around 7.9 per test, and that there are global campaigns that are ongoing, which I think is led by Mrs. Fontier, on dropping the test cost for other diseases, including viral hepatitis, both B and C, to below 5. So I think at some point, for access to diagnostics and in reducing the cost, expanding access, I think we all need to work together with other advocates who are working on those same diagnostic tools and improving access to that. So I just wanted to note that. For our work specifically, I think we work majorly with physician groups, patient groups, community civil society groups. We've been working on access to medicines movement, not only for hepatitis B, but also for hepatitis C and HIV for a long period of time. We will continue to work that. On viral hepatitis front, for access to treatment, it has been a lot of HIV activists and HIV treatment advocates who have led the way. We were part of that in terms of access to generics for hepatitis C. And I don't see any reason why we won't be able to do that in the same way for hepatitis B at this point. I also heard in the summit about manufacturers in Africa who are coming up with TDF, or already in the market, although it's not to the, pricing is not as low. Negotiating with them, talking to them in terms of, what they could offer is really important. So finding those solutions are important. We will continue to work on those fronts. We would train the people. People get very complicated, when it becomes hepatitis B because of the series of tests that are there and what denotes what. We will continue to simplify it. We'll develop fact sheets of these guidelines. We'll continue to train community people. We'll continue to train community of trainers. We will work with physicians as we have done in the past with our WHO regional offices, hopefully very soon, to train physicians on this new guidelines and how this could be adapted. And also with other treatment access groups on ensuring that hepatitis B, in terms of both diagnostics and access to expanding this treatment and making sure that the eligibility expansion with relation to this new guidelines is if not entirely adopted, preferably it's adopted in a complete way, but it's adapted in some way very close to what we see here. Also, not to forget, again, the chapter 5, where a patient and the physician feels comfortable knowing all the pros and cons. Anybody could be on treatment irrespective of all the criteria that has been laid out. So we'll be taking all steps in the coming months to make sure things are taken forward. Over, Catherine.
Thank you so much, Gitin, and thank you also for making that important point of making it a patient-provider conversation and decision that's shared for treatment initiation. Adesua, I was wondering if you could also share what your next steps are for implementation in your community-based organization in Nigeria. Over to you. And I'm glad you were able to join us. I think your connection may have been a little unstable as well.
Yes, so sorry about the break in transmission earlier. Yes,
no problem.
Thank you. Yes, I would like to say from now we're going to continue to see how we can work with the Ministry of Health in solving the challenge of Brown, which is the limited diagnostic equipment, accessibility, and the high cost of medication. And we do just as Dr. Gitin rightly mentioned earlier, we'll try and see how we can get that done. And I also like to add that the WHO and international donors, if they can actually support CSOs, since we are the ones directly implementing this guideline, if they could support us directly and not just through the Ministry of Health, because we have realized that most CSOs have actually been existing on their own without getting any assistance from their Ministry of Health. But if these international donors could actually support the CSO directly, then of course no CSO will carry out any project without the help of the Ministry of Health. So I would just like to thank that. Thank you, Peter.
Thank you so much. And thank you for your work on the ground to raise awareness in the profile of hepatitis B. Wendy, maybe you could also add what your next steps are and also thinking about implementation of these guidelines.
So, I mean, our 2019 guidelines for viral hepatitis, which really didn't get off the ground, obviously for hepatitis B were quite complex. I think looking at the updating, which is due to happen this year, these would be very easy to update to, and I think would have much greater, people would be much easier to sort of uptake this and understand these new criteria for initiation of therapy. I think the big thing is if we look at universal vaccination, which was introduced in 1995, we took our prevalence down from 9 and we're sitting at about 5%. Really, unless we actually upscale birth dose vaccine, I don't think we're going to have a major impact in bringing down that prevalence. So at the moment, we've got targeted therapies since the end of 2023. If we surface antigen positive, then the neonates will be vaccinated. But I think we really have to push hard to actually have universal hepatitis B vaccination. I think without that, we're not going to. And you know, it's the opportunity then to screen and vaccinate or link to care partners, siblings, and other children. And I think the important thing is really the dissemination over and over again. I mean, one webinar, a few webinars is not enough. One needs to actually have regular webinars. And so we've really started in Project ECHO with, I think, a week ago, where we looked at and relating it to cases. And I think that's the way to actually make it a living document, is that when you present a difficult hepatitis B case or a simple case, actually relating back to these guidelines. So what we'll be looking at is to, when we run our ECHO programs, actually to relate treatment for hepatitis B back to these guidelines. Thanks. So I think education is important and it needs to be ongoing all the time. and particularly, I think we need to change the way that we, as Mark always says, how we treat our students, how we teach them. I think, and this is a really a good platform to start. Thanks.
Thank you so much. I couldn't agree more regarding the universal hepatitis B vaccination. We have a wonderful tool that's been available for more than 30 years that can really prevent infection, and we should really be thinking about wider implementation of that. And then also appreciate the case-based learning and thinking about the guidelines and training our future generations, but also the providers on the ground now to really think about how they can apply these into practice. Philippa, over to you for next steps from the WHO side.
No, thanks so much. And obviously a key part of our, dissemination is through exactly this sort of webinars, to have that Q&A and to have it further cascaded, because there are still a lot of questions. But I think for me, a key priority is really to have the national ministries of health, the programs to really rapidly adopt these guidelines. I have 12 countries that I already know are moving forward. And I think to have the community, the NGOs, as an integral part of this. And then the next wave of countries that haven't quite thought about their Hep B guidelines, to have the community as real partners in driving this forward and saying, please, these need to be updated. So I think phase 1, phase 2, I think I'm very keen that there is some form of community toolkit that has the main messages from the guidelines, has the implementation consideration, particularly as they relate to the community, to have you all absorb those key messages so you are very informed advocates to your national programs. And I think to have that assembly, as I know the Hep B Foundation is doing, of all the kind of great tools that are out there for educating the community and the patients, and what questions to ask. And those are very important. So I think those are probably the priorities moving forward, spreading the word, getting articles out, pamphlets, to really ride on the crest of the momentum that we currently have. And thanks for all the great questions.
Thank you so much, Philippa, and to all of our panelists really for sharing their unique experiences and expertise and feedback. In terms of the Hep B Foundation and the role of civil society, I think all of us on the line have a lot in terms of need for advocacy at our local levels and also global levels to really work towards ensuring that these guidelines are widely adopted. But I want to share some additional resources that might help in the adoption, particularly the community educational resources, which is linked at the bottom of this slide here. It includes a wide array of hepatitis B informational fact sheets in multiple languages. Feel free to reference those. And you can also add your own resources to this by filling out a survey that's on the line. We want to make sure that we're being as comprehensive as possible and creating a catalog of all things hepatitis B that can be used and adopted in various communities. There was also a recently published Lancet Journal article of which Dr. Easterbrook was an author, which is referenced here, which is really a high-level overview of the guidelines, as well as the patient preferences that went into the guidelines and incorporating those. I'd like to take a moment to also thank our panelists for spending their time with us this morning and sharing their expertise, and also thank you as attendees for joining the webinar. As a reminder, you'll be getting a survey following the webinar in your email. Please provide some feedback to us and any suggestions or additional questions that you might have. This will be in your email following the webinar, and we will also be following up within the next few days with the recording of today's session. Please feel free to share that with your networks and your colleagues. We want to do the best that we can to make sure that these guidelines reach far and wide and are widely implemented in our local communities. So with that, I'd like to conclude. And again, just thank our panelists for being here and spending the time with us this morning or afternoon. I know it's late for you as well, Gitin. So really appreciate you guys being here and spending time with us. And thanks to all of our audience members as well.
Thank you very much.
Thanks, everyone.
Bye.
Bye.